pelvic fracture. Okay, it emerged, femoral emerged between the iliopsoas muscle. Okay, so it can be compressed in the case of mass invading iliopsoas muscle. Okay, like hematoma, abscess, psoas abscess. In these cases, you can have, okay, because femoral nerve emerged between iliopsoas muscle. So in those muscle masses, you can have issue of femoral nerve. Okay, and remember, very hygiene point. Femoral nerve L2, L4. Okay, when you have an issue of this nerve, you will have decreased patellar reflex, decreased leg extension. Okay, this high yield point. Okay, here what are the quadriceps? You know, rectus femoris, vastus lateralis, vastus medialis, vastus intermedius. That are quadricep muscles. There are four muscles that do leg extension. Next is a sciatic nerve, L4 to S3. It is motor to, you know, posterior thigh muscle. In one word, you can cram in this anterior thigh muscle, posterior thigh muscle. Motor is to semitendinosus, semimembranous. Okay, bicep femoris, inductor magnus. Here you can see if we have node obturate, adductor magnus is supplied by two nerve. One of them is obturator nerve. Okay, also other is the sciatic nerve. Okay, okay. When you will have issue of sciatic nerve, it will be in the case of herniated disc, posterior hip dislocation. Here we have discussed anterior hip dislocation. Okay, and here is posterior hip dislocation. Okay, split into common peroneal nerve and tibial nerve. Okay, okay. Next is the actually two branches of, okay, sciatic nerve. Guys, this question is so high yield. Okay, you will remember it. Also mnemonic are given for both of them. Common fibular nerve mnemonic is, okay, dropped. Okay, this is a mnemonic. PED, peroneal everse and dorsiflex. If injured, foot will be dropped. Loss of sensation on the dorsum of foot. Here you can see dorsum of foot. When you will have foot dropped, okay, because it everts and dorsiflex, you will have inverted and plantar flex foot. So easy. Okay, so this is the outcome you want. Everything is covered. A common fibular nerve. Okay, here you will remember a very high yield point. Okay, fibular neck fracture is high yield. Okay, because at fibula neck, okay, this nerve is present. Okay, so first of all, it is present when when sciatic nerve is present at the posterior side. Okay, and the posterior, okay, I will say knee. Okay, it will divide into tibial nerve, fibular nerve. Then fibular nerve will actually you will say move around fibula at fibular neck and then come interior side, anterior leg. There are two nerves, superficial peroneal and deep peroneal. Okay, this is for lateral leg, okay, and it this is for deep peroneal nerve is for anterior leg. Okay, here it will go to lateral compartment. Okay, sensory to dorsum of foot, accept web space between hallux and second digit, because this area is supplied by deep peroneal nerve. It is motor to two muscles, peroneus longus and brevis. These are lateral thigh muscle. These are lateral leg muscle, peroneus longus and brevis. Reperoneal, it is for, okay, sensory to that area that is not supplied by superficial. Motor is to tibialis anterior. So the deep peroneal nerve is a nerve of anterior leg. This is a nerve of lateral leg, and tibial nerve is a nerve of posterior leg. Here it is, okay, here it is sensory to sole of foot. Here you can see, okay, motor is for biceps femoris, triceps surae, plantaris, popliteal, flexor muscle of foot. Okay, so it can be tibialis posterior, that is a main muscle given here, tibialis posterior. Okay, so in which cases you can have damage to tubular nerve, knee trauma. Most important is this one, Packer cyst. In Packer cyst, we will discuss. It will be given in osteoarthritis, in rheumatoid arthritis. Okay, in those conditions you will have, okay, a cyst will form. Also in the distal region, okay, it will be tarsal tunnel syndrome. Okay, at this location of the ankle, you will have tarsal tunnel. Okay, so that's it. Here is also on a given tip. Okay, tibial inverse and plantar flex. If injured, can't stand on tiptoes. This is high yield one. Can't stand on tiptoes. It is tibial nerve. Okay, inability to curl toes and loss of sensation on the sole. Okay, so that's all about. Okay, remember. Okay, see the difference between them. Foot drop and can't stand on tiptoes. Okay, so these are three lines just you have to grab. Okay, you can clearly see these three lines and these. These are high yield. Both are high yield. Can see the compare. Can compare them. Superior gluteal nerve supply these muscles. Most important are gluteus medius and gluteus minimus. Okay, here you can see they actually support the contralateral side. Here you can see, suppose this is the right side gluteus medius minimus support the left side, withhold the left side. When you will have a weakness of this muscle, contralateral side will drop. The contralateral side will drop. Okay, it is common in, okay, intramuscular injection. Okay, to spiromedial gluteal region. Okay, so remember. Okay, you can see. Okay, this is spiromedial, spirolateral. Okay, inferior lateral. Okay, okay. So when injection is given in this region, okay, you can have injury to superior gluteal nerve. When injection is given in this region, you can have injury to sciatic nerve. Sciatic nerve. So this region is safe. Spirolateral is safe. There is a sign, there is a Trendelenburg sign, pelvic tilts because weight bearing leg cannot maintain ailment of pelvis. Okay. Lesion is contralateral to side of hip that drop. If this hip drop, lesion will be contralateral. Okay. Remember, inferior gluteal nerve supply the gluteus maximus. Sometimes we confuse. Superior gluteal nerve is for, okay, small muscle. Inferior gluteal is for big muscle, that is the gluteus maximus. Again, it will be in the case of posterior hip dislocation. Okay, you will have difficulty in climbing stairs, raising from seated position, and loss of hip extension. Okay, so in this case, you will have loss of hip extension. Remember, yeah, pudendal is very high yield. It is sensory to perineum. Motor is for these anal sphincter. Okay, and it is motor to some sphincter, anal sphincter and urethral sphincter. And guys, remember, whenever you will have pudendal nerve injury, you will have incontinence. You will have you will have fecal incontinence, you will have urinary incontinence. Okay, this is a hygiene point. In which cases you will have injury, most common is the stretch injury during childbirth. Okay, arrested second stage of labor. So that is the most common cause. Second stage of birth is labor is arrested. Prolonged cycling, horseback riding. So this question have been asked in your, this is have been asked. So you have decreased sensation in perineum caused incontinence. Okay, so this is the important MCUs. Okay, can be blocked with local anesthetic during childbirth. using ischial spine as landmark of injection. So you will use ischial spine as a landmark. So that's all about lower extremity nerve. Then you can see the, okay, here you can see the mnemonic lamb, lateral femoral condyle to anterior tibia, it is ACL. Medial femoral condyle to posterior tibia, PCL. Here guys, you will remember landmark is tibia. Anterior tibia, you will have ACL, posterior tibia, it is PCL. Okay, so tibia is important in this case. Then the entire anterior triad sign. Okay, here you can clearly see that when ACL tear happen, tibia will glide anteriorly. Okay, that's why I have told you that tibia is a actually important point here. In PCL, okay, tibia will glide posteriorly. Okay, in the PCL injury. Okay, so interior triasan, bending of knee at 90 angle, interior gliding of tibia due to ACL injury. Same in this case, bending at 90 angle, posterior gliding of tibia due to PCL injury. Okay, so in these triasan are for, it is for ACL and this is for PCL. Next is abnormal passive abduction. Abduction and then abnormal passive adduction. So here you can see that in MCL injury, okay, in MCL injury, okay, medial collateral ligament and LCL injury, lateral collateral ligament, okay, you will have in this case, okay, when you put the valgus force, lateral force, you will have medial spacing, the medial space widening of tibia. Here you can see, okay, we have put the valgus force, okay, here it, medial space is widened. It will be occurring. So medial space widening, it is in medial collateral ligament. Lateral space widening, it will occur in the case of actually LCL tear. Then always remember, force will be applied on the opposite side. Okay. When I am checking medial space widening, I will put force on the lateral side. So if medial space wide, it is MCL injury. Then to check LCL, I will apply medial force. If lateral space widen, so this is LCL injury. Sometimes students confuse. Okay, which space wide? It means that collateral ligament is damaged. If medial space wide, that is MCL injury. If lateral space wide, that is LCL injury. Okay, then force applied will be opposite to that. If I am checking medial space, I will apply lateral force. Okay, is the right? It's so easy. Ram as in this. Then Mercure test during flexion and extension of knee. Okay, with rotation of tibia. Okay, so here is so awesome mnemonic line. Pain popping on internal rotation and varus force. It is lateral meniscal tear. Internal rotation stress lateral meniscus. Pain and popping during external rotation. It is medial meniscus tear. External rotation stress medial meniscus. So lateral rotation. Okay, lateral meniscal tear in internal rotation, medial meniscus tear in external rotation. So awesome mnemonic is given of line. Then are the ankle sprain. Okay, so here MCs was given anterior talofibular ligament. It is the most common ankle sprain overall, classified as low ankle sprain. Okay, so this is anterior talofibular ligament. You will remember it. Due to over-inversion and supination of foot, always tear first. So these MCQs have been asked in U world. Okay. We most common ankle sprain is, okay, you will have just pain in the ankle. Okay, X-ray is normal. Okay, so that is sprain. Ligament is anterior talofibular ligament. and it is due to, okay, so that's all. Then anterior inferior tibio-fibular ligament is most common cause of high ankle sprain. Here you can see low ankle sprain and high ankle sprain. This is most common cause of high ankle sprain. Okay, that's all about. And you will remember always. Okay, next is the important MCUs. Metatarsal fracture. This fracture, metatarsal fracture, is common as stress fracture. So this is not given in the book, I think. Stress fracture. Stress fracture. It will be common in, in military soldiers. Okay, this is also called okay, march. Okay, this is also called march fracture. During marching, during parading, okay, you will have stress fracture in the metatarsal. Most common is the fourth and fifth metatarsal. Okay, you can also have callus formation in this side. Okay, okay, you will remember it. This is the most common stress fracture. Okay, if you have started abruptly walking or running, jogging, or you in military parade, if you are female, you are prone to stress fracture. Okay, so that's all about. This is metatarsal. If metatarsal fracture is given and you have started, history will be given up sudden onset of starting running. Okay, it can be military, it can be anybody, and fracture is given of metatarsal. So you will classify this fracture as a stress fracture. Okay, that's all about. Then I will send another link for radiculopathies.